A young male who's just got a desk job and leads a very sedentary lifestyle, gives you a history suggestive of OSA. You can see he's got a very short, thick neck, and the partner tells you that he snores very heavily at night and wakes up feeling extremely tired in the morning. On his preoperative labs, you find that his A1C is slightly raised. He regularly consumes alcohol, has got a quite high BMI of 46.8, and you perform a laparoscopic RYGB for this particular patient, and later on he has absolutely no complications. He directly comes to you 1 year after the surgery. He's not followed up at all. He still claims that his appetite is poor, but he's not following any kind of exercise regime. His alcohol intake continues, and his BMI, even after 1 year, is only 41.9. So there is hardly been any kind of weight loss. The percentage excess weight loss in this case is less than 20%. Dr. Bharucha, what would you do next?
Well, it is obvious that this guy needs to be disciplined slightly more. No, I don't know. I don't really know who is going to take charge of disciplining him to reduce his alcohol intake, which is probably the main reason why he's putting on weight, because the calories that you get by alcohol are very different from the calories you get in anything else, and your body also treats these calories differently. Till the alcohol calories have been burnt out completely, your body will not utilize any other food form, like any carbohydrate or fat or anything, calories from that to burn. So it will preferentially burn calories from alcohol. The most important thing is to get this guy off the alcohol. If you can get him off the alcohol and get him onto some kind of regularized following some kind of a regularized diet, and get him to do some exercise. I mean, you said in the previous this thing, right? Is he working out? Is he doing any form of exercise? Because the other thing we have to realize is not just exercise, it is continuous activity that is more important than just doing 30 minutes of exercise every day.
Right.
So
it has to be an active lifestyle.
Yeah, does he have an active lifestyle, or is he just exercising every day? You showed something in that slide. Exercise.
He's not exercising at all.
Not exercise. So diet and lifestyle, I think, should be the main things, because if he's going to continue to have alcohol, he's not going to exercise. No matter what you do surgically, is going to help him.
Right. Dr. Praveen, sorry.
So I think I would pursue that doggedly till maybe take it to an extreme before I decide to do something surgical.
Right. Dr. Praveen, any other reasons or any other predictive factors, not necessarily in this case, but overall for inadequate weight loss?
Asking about predictors as such, then the preoperative weight loss is the only predictor that you have to know that somebody will lose weight post-operatively or not. So like in the previous case, that's why I was dwelling on the question of why did she lose 13 kilos? How did she lose those 13 kilos as such? So in this patient, yes, if he had taken a proper history of what he did, because again, I think, just to have give you a devil's advocate, the failure of the surgery and the outcomes may not necessarily be his alcohol lifestyle alone. Maybe the surgery also could have played a role, because many times, even with the drinkers, a good surgery gives results, just that their poor lifestyle makes them regain back the weight. Because inadequate weight loss also might contribute something to the surgery by itself also. So a good understanding what happened preoperatively, did he follow any regimens? Did he lose any weight? So that is why I think most of the Western centers, I think the insurances never cover unless the patient has gone through an intensive lifestyle modification regimen and has shown some result. They don't cover for bariatric surgery at all. So I think that should be the most important thing that we should look into, because once you've operated, it's your responsibility. I think we cannot blame the patient.
Yeah, exactly. It's like Dr. Pali mentioned in his talk, you are basically married to every patient that you operate upon. One of the other things which I believe could be an incorrect surgical technique. If you've got very short limb lengths, it's highly possible that the patient has not had enough malabsorption. Here in this case, we have got a multitude of factors, but again,
I'll just interrupt here, Nidhi.
Yes.
What Praveen just said about playing the devil's advocate, if we had more information in this particular case on what was the initial weight loss that he achieved after surgery, immediately post-operative in the first 6 months, would help us determine whether the surgical technique was correct, and whether that was not one of the reasons why he did not lose adequate weight. And as we all are already aware that he, in this particular case again, that he was already consuming alcohol and performing an RYGB in a person who is a regular consumer of alcohol. Over a period of time, the affinity towards the consumption of alcohol only increases. So that's going to be an Achilles heel for this particular person.
Dr. Palip, how would you further manage this case? Dr. Bharucha has already highlighted the importance of counseling. So apart from that, what else would you like to do?
So again, I don't. I completely agree with Dr. Bharucha that, in this particular person, we will have to go into severe lifestyle management counseling, but also repeat an endoscopy, probably to check, if the anastomosis is still a small, nice small anastomosis of GJ, which is 2 and 2.5, so between 2 and 2.5 centimeters, and has not become really big. Find out how much the patient is able to eat in one go, what are the portion size of his meals, and what exactly is he consuming. So going back to sitting down with the dietitian and trying to figure out what are the do's and don'ts as far as the diet is concerned, more importantly.
Right. Fair enough.